I'd like to introduce our next speaker to my colleagues. Our next speaker is Professor Paul Jones. Professor Paul Jones is gonna speak to us on the topic of translating clinical trial data into the real world of COPD. Professor Jones is a global medical expert of the GSK GlaxoSmithKline, and he is a professor of respiratory medicine at the St. George University of London. He is the guy who developed the famous St. George Respiratory Questionnaire and the other famous questionnaire that we use up today in our daily practice, such as the CAT questionnaire for COPD patients. The CAT questionnaire is the COPD assessment test, and he also contributed to the development of the exact COPD exacerbation diary. He is a member of the science committee at the board of the GOLD, the Global Initiative for Chronic Obstructive Pulmonary Disease, for more than 10 years. Professor Paul Jones, it's an honor and pleasure to have you here with us. The floor is yours.
Thank you very much, Ashraf. Very nice to see you, at least by video, as opposed to meeting you in person again. I feel like I expect if we were in a live conference, at this point, many people would be leaving the room because they've come to hear the really interesting, exciting developments. But I'm going to be talking about COPD that we understand well, but still raises some important questions. Okay, so I'm going to be talking about translating clinical trial data into the real world of COPD. In fact, it's not disease specific, but the example we're using is COPD. I should point out that I'm also a GSK employee at the moment, but I try not to let that influence my talk. Okay. Now, I want to start with three clinical trials with different drugs done in different patients, different inhalers, but they definitely answer the question of what's the benefit of adding ICS, so that means triple therapy, 3 drugs, ICS, LABA, and LAMA, together in one inhaler compared to dual bronchodilator. On the left, we have the Tribute study, in the middle, the Impact study, and on the right, the Ethos study. The answer is there. The addition of ICS to dual bronchodilator clearly reduces moderate and severe exacerbations in the patients for whom the drugs are indicated. There's no argument now. Now let's look at another aspect of COPD, the symptoms. These data come from the Impact study, and it's a responder analysis of the proportion of patients who had a clinically significant improvement in SGRQ with the 3 drugs. On the left is triple therapy, in the middle is ICS LABA, and on the right is LABA LAMA, or dual bronchodilator. And what's really interesting, if we compare the blue bar and the orange bar, we see the expected symptomatic benefit, the health status benefit of adding a bronchodilator, adding a second bronchodilator. But look over here on the right, we get exactly the same symptomatic health status benefit from adding an ICS to a dual bronchodilator. We've tended to forget the symptomatic benefit of ICS in recent years. But the key question is, do these findings translate into benefit in clinical practice? So let's look at where the evidence comes from. So all drugs have to be studied in a phase 3 trial. That's the evidence source for guidelines, for the license, and for clinical practice. But their primary purpose is to test efficacy, to assess safety, and to get a license to market the new drug. And you can think of them as being performed under what I've called laboratory conditions. It requires careful training of the patients, high treatment adherence, close monitoring, and many measurements. And the inclusion and exclusion criteria are very important. And the reason all these strict rules are put in place is that to try and avoid bias in the results. By that, I mean to ensure that the results really do show the efficacy and the safety of the treatment. The problem is the design of these phase 3 trials introduces their own biases. So let's look at the effective inclusion and exclusion criteria. I'd like to thank my colleague, Professor David Halpin, for this slide that he published a few years ago, looking at nearly 40,000 patients who potentially could be recruited to a COPD trial in primary care. We see that a third of them could potentially be recruited, actually were their FEV1 was out of range, and then we see the numbers drop off until we get to the end, and we see that only 13% of potentially eligible COPD patients could enter this trial of dual bronchodilator. So we see in the trials a very restricted type of patient. So what about the effect of run-ins? Of course, in clinical practice, we don't have a run-in before changing treatments. We don't say, I'll put you on this treatment, and after 2 or 4 weeks, I'll switch you to another one, unless there's some special reason. This is a characteristic and an important characteristic of clinical trials. And let me see how that might influence things. These are data from the FLAME study, and this is a consort diagram. And we see that out of the 5,300 patients who were screened, about 400 failed the screening for different reasons. Then there was a 4-week run-in period on tiotropium alone. And now 32% of patients dropped out during the run-in. They met the inclusion criteria for the trial, but for one reason or another, they couldn't stay for 4 weeks just taking tiotropium. And then, of course, at the end, they were randomized to have dual bronchodilator or ICS/LABA. So there's a bias. What about adherence during the trial? Now, we want to know how effective the treatment is. So we need to have 100% adherence. Actually, in clinical trials, it's not bad. It's between 70 to 80%. But in clinical practice, it's much worse. It's less than half of that, between 10 to 40% in COPD. And of course, COPD is better than asthma in terms of adherence. So adherence in routine practice is low. What about inhaler use? And first, let's look at inhaler use during a trial. The patient's technique is checked at every visit because the drugs only work if they get down into the lungs properly, and they'll only get down into the lungs properly if the patient uses the inhaler correctly. And different inhalers have got different rates of critical errors. On the y-axis here is the proportion of patients who were tested who had a critical error. And the critical error is one that occurs that could result in the drug not being delivered adequately to the lungs. Means that the drug won't work. And there were 5 comparisons here, all of them against the Ellipta. On the left, Ellipta against Acuhaler, then in blue, Ellipta against the metered-dose inhaler, green, Ellipta versus Turbohaler, then yellow, HandiHaler, and red BreezeHaler. The way this study was done is none of the patients had used the inhaler before they were studied, and they were given the instruction leaflet to read, and then they were tested, observed very carefully using a checklist to see whether they made a critical error. you can see that the error rate varied between 5 to 50%. With the ellipta, it's lower than the others, but even so, 1 in 10 patients failed to use the ellipta correctly if they just read the instruction leaflet. And of course, you can see it's clearly worse with the other COPD inhalers. So inhaler training is essential. Now let's think about triple therapy. There are basically 2 ways of delivering this. One is what I call MIT, multiple inhaler triple therapy. That usually means using an ICS LAMA twice daily and a LAMA usually once daily. The alternative is to use 1 inhaler, and I'm going to call SIT, and that means 1 dosing regime. Now that might be once a day, or it may be twice a day, but it's a single dosing regime using a single type of inhaler. Now I've shown you the errors about using single inhalers. This is a very similar study now, looking at errors using 2 inhalers. So this is, again, on the y-axis, is the percentage of patients making 1 or more critical error after reading the information leaflet. There in black is the single use of the ellipta, and on the right, we see a combination of the AccuHaler and HandyHaler. And now it's 75% of patients will make a critical error with 1 or both of these inhalers. And it's the same whether the patients use a turbohaler or HandyHaler. So using 2 inhalers very greatly increases the risk of an error in the way the patients use it. Now, something else that happens in a clinical trial is something that's called the Hawthorne effect. And what that means is that the person's behavior when they're being watched alters their behavior and their outcome. And it's very common in clinical trials. Here's data from the TORCH study. This is the change in SGRQ over 3 years. In gray is placebo, and in purple is salmeterol fluticasone, so serotype. But the reason I'm showing you this is look at the first year. There is a significant improvement in the patient's health status, even though they were given placebo. Probably all sorts of reasons for that, but this is a very common effect. This is, of course, one of the really important reasons why we need to have comparator groups in randomized controlled trials. Now, there are different types of therapeutic study. This is a slide from Professor Roche in France, characterizing 4 different studies. What I've been talking about so far are what Professor Roche calls highly controlled trials in patients with the pure diagnosis. These are the phase 3 trials. But there's another important group of trials that he calls pragmatic trials and are often also called effectiveness trials. And now I'm going to talk about the difference between effectiveness trials and the phase 3 trials. And here's a table. So in the middle, I've got an efficacy RCT, so the phase 3 trials. And on the right, I've got an effectiveness RCT. So let's look at the setting first. As I've explained, an efficacy RCT is done in a tightly controlled environment, whereas effectiveness is in routine practice. In an efficacy trial, it's double-blind and often double-dummy, whereas most effectiveness studies are open-label. The comparator treatment in an efficacy trial is precisely defined, whereas in routine care, it's usual care or the physician's discretion. Adherence is strongly encouraged in an efficacy RCT, and it's whatever the healthcare practitioner usually does in routine practice. The inclusion criteria for a trial, as I've shown you, tightly defined. In an effectiveness study, the the inclusion criteria are minimal because in an effectiveness study, we want to recruit a typical group of COPD patients. The assessment in an efficacy RCT is regular and frequent, often every month. In an effectiveness study, it's like routine practice in most places in the world, minimized and often very little. And finally, very importantly, when it comes to patient adherence, the patient in an efficacy trial is given their drug at every visit, whereas in an effectiveness study, they have to take the prescription, go to the pharmacy, collect it, pay for it, and pick it up. So you can see the very big difference between these two types of study. What an effectiveness trial is trying to do is avoid some of the biases that are inherent in efficacy trials. So here is a very recent effectiveness study in COPD. It's called the Intrepid study. 3,000 patients were randomized either to have triple therapy, in this case, Trelegy with the Ellipta, and the other arm, the bottom arm here, these are patients who had multiple inhaler triple therapy using inhalers other than the Ellipta. If we look at the baseline demographics, and I won't go through the details, take my word for it, they were very well matched at baseline. That's one of the advantages of randomization. Also, in terms of the treatment the patients had been taking before they entered the study, you can see it's almost, in fact, these numbers show they are identical between the SIT patients and the MIT patients. So very well matched. This is one of the big advantages of an effectiveness study like this than a database study where you try and match the patients after the event. So this is, in fact, the secondary outcome. I'll come to the primary in a minute. Looking at the improvement in FEV1, this is from baseline after 6 months. On the left, in orange, is the triple therapy, and on the right is the MIT. And you can see a significant difference in FEV1 between the two treatments, triple therapy being more effective. But the primary endpoint was actually a patient-centered endpoint, and this was a responder analysis using the CAT. And we can see that using SIT triple therapy, the odds ratio for a clinically significant benefit was 1.31, highly statistically significant compared to using MIT. What that 1.31 means is that there's a 31% greater chance of a clinically significant improvement with single inhaler triple therapy compared to multiple inhaler triple therapy. I am very impressed by that result because let's just look at the right-hand side. These are patients whose treatment basically hasn't changed. All that's happened is that they've entered the trial, but 40% of them have got a significant improvement in their health status. So again, we are seeing this clinical trial effect is present even in effectiveness studies because going into a trial alters people's behavior. So what could the benefit of SIT be due to? Is it one inhaler versus two? Is it the dosing, once daily versus once plus twice daily? Is it the duration of action of the molecules in the drugs? Or is it perhaps using one inhaler for all 3 drugs? Now, I'd love to talk about the other 3 questions, but I've only time to address this last one. Is there a benefit of putting 3 drugs in one inhaler? Now, this is an unusual study. It was quite a large study, a 24-week study designed actually to test for non-inferiority between the 2 treatment arms. The top treatment arm was a double-blind, double dummy allocation. So they were having Trelegy, in this case, plus an Ellipta placebo, and the other arm was relvar-brio plus umeclidinium. Double-blind, double-dummy. So you will realize that both treatment arms had the same molecules, the same inhaler, the same number of inhalers, and the same dosing regime. So in theory, the results should be exactly the same. Now, the study wasn't powered to detect superiority of one treatment over the other, but this is a change in trough FEV1 at 4 weeks, slightly better with the triple therapy, but with the single inhaler. But over the next few months, we see the two treatment arms converge. But remember, it's not statistically significant, but there is a clear trend there. And remember, these are exactly the same drugs being given, but in orange, they're being given with one inhaler. It's the same with the improvement in SGRQ. So this figure on the left at 12 weeks is the improvement from baseline. And we can see that the improvement with baseline with the triple therapy is bigger than with the two inhalers. And actually that difference gets bigger, gets bigger at 24 weeks. Again, it's a trend. It's not statistically significant. I should also say that the exacerbation data show the same trend. Now, this has actually been seen before. When ICS larvas were being developed, a number of studies compared putting the ICS larva into a single inhaler, in this case Seretide, compared to giving the same drug, so fluticasone and salmeterol, in two separate inhalers. Here's a meta-analysis. Quite consistently, this is in asthma, I should say, quite consistently, the FEV1 was better with the ICS larva single inhaler, and the meta-analysis shows a clear, significant benefit of using Seretide compared to Flixotide and Serovent given separately. So what are my conclusions? Phase 3 efficacy trials are designed to provide an estimate of a treatment's efficacy and safety, but they've got strict inclusion and exclusion criteria, and they require close observation of the patient. Effectiveness randomized trials try to mimic routine clinical practice. You've seen that they can have very well-balanced treatment groups, unlike problems that occur with retrospective database analysis, but they provide very limited information about the mechanisms of benefit, and the patients, as we've seen, still know they're in the trial. And it's clear that it's not a case of one or other. Both types of randomized trial are needed because they provide complementary information. So with that, thank you very much for your attention.
Thank you very much, Professor. That was very nice to review over the importance of this translation of clinical trial into real life. So if you would allow me to summarize the points that you talked about, you initially mentioned how clinical trials can have a significant dropout of patients, from 1,000 up to 1,500 out of 5,000 patients can drop out in 4 weeks just because of the strict clinical trial protocols that do not suit many of our patients in the real life. At the same time, you nicely outlined how in order to assess efficacy of a drug, you need such a high adherence of up to 70 to 90%, where we know that most of our patients do not reach this high adherence level, unfortunately. And there have been studies that suggested patients actually don't tell you the truth when you ask them about their adherence, just simply because they want to keep you pleasant and make you feel good as a doctor. Now, this low adherence can be a problem. Then your point about critical errors, how important it is. Even in the best inhaler, you still can have 1 in 10 patients having a critical error leading to not delivering the right medicine. And last but not least, you nicely showed that sometimes it's not the molecule, it's not the device. The same patient just going into the clinical trial and not even taking the active treatment being studied, they're taking the same placebo, quote unquote, medicine, they still continue to have 40% improvement just because they are in a clinical trial being monitored. This tells me that this relationship between the doctor and the patient is really important, and this behavioral change can be seen only if there is a strong trust relationship. You
Yes.
did mention in other international trials, Professor John Paul, that there were side effects or negative impact for critical errors, such as hospitalization, more ER visits. Don't you think this is strong enough that researchers should focus on this? So the device and compliance with the device and adherence rate being higher with better devices should be a real focus for investigations?
I agree. I mean, there is one very nice Italian study showing that exacerbations and hospitalizations are higher in patients who make a critical error. And it's obvious, isn't it? The inhaled treatments only work if they get into the lungs and they don't end up in the mouth. And it's also cost effective. It does take a little bit of time to train the patient, although with dry powder devices, it's quicker usually, only a few minutes. So it doesn't take very long time, and the benefit for the patient, and if you like, the overall cost effectiveness of the treatment is enhanced. And of course, if you train the patient properly, a patient will tend to use inhalers, treatments that work, they're getting benefit. They very sensibly, if they're not getting benefit, they won't use it. So they'll lose faith in the drug and they'll lose faith in you. So ensuring that they're going to get the maximum benefit by taking that little bit of time to train them how to use the inhaler, I think pays many dividends.
And if I would share this with you, this thought of our struggle sometimes to train our patient. To be honest with you, it's not easy to get those demos from pharmaceutical partners. And I'm actually sending this message to our pharmaceutical partners because I've been struggling even to record a video for inhaler device demos to post it on our Emeritus Thoracic Society. The president of the respiratory therapy special interest group in our society, Dr. Manjush, has been recording some videos for patients how to take their inhalers to post it on the website for patients in different languages. And I can't tell you how difficult it was to get some of those inhalers even for demo. In my hospital, according to the JCI accreditation, you're not supposed to do a demo with a live true inhaler that has active molecule to it. I don't have demos. I have to empty an inhaler to do the demonstration and I have it in a basket. What do you think? I think there is a lot to be done there.
Yes. Now, I have a lot of sympathy with you because ever since the 1990s, I have been starting inhaler treatment by trying to train the patient first myself. I start the training. I often have to hand over to a nurse, but I always start the training. And I agree with you. Demonstration devices are really important. And one of the things I like about devices like the ellipto training device is that it makes a sound and it's disposable. You can give it to the patient, say, take it home, and every month you or a family member just check that you can make that sound breathing in. It's made a big difference. Now, I have limited influence in the world, but I can pass your message on to GSK. It's really important. As a still practicing physician, I think demonstration devices are really important. I will pass that message on, at least for one company.
Sure. And I'll have to say also, your point is about the fact that single inhaler versus multiple inhalers, even if it's the same molecule, the same company, single inhaler has a better adherence and hopefully a better outcome. This is also important to talk about. I have a question from Dr. Muhammad here. General question about COPD. How do we state COPD to know which stage the patient has in the current COPD guidelines?
Okay, so one of my confessions, one of the things I may have done right or wrong in the past was to move GOLD away from just using the FEV1 to creating the ABCD system. It's not perfect, but it starts focusing the clinician's attention on what's important to the patient, their symptoms and their exacerbations. We hear quite a lot now, and maybe Ian Pavord will talk about treatable traits in COPD. And that's a very interesting concept, but even practically, we can identify the key issues for the patient and base our treatment on that. So their level of symptoms, and you don't even need to use a CAT, just ask if the patient is breathless walking up hills and stairs. And you can ask about exacerbations. So that's the background to the GOLD ABCD structure, because we know that the FEV1 is a very poor, it measures lung function very well, but it doesn't measure the effect of COPD on the patient themselves in terms of symptoms and exacerbations. So to me, measure spirometry to make the diagnosis, but then ask 2 or 3 key questions. Is your breathing affecting your daily life? And do you get chest infections that affect your daily life? And that, I think, is how we should be basing our treatment.
Professor Paul Jones, it's been a pleasure having you, and it's always good to see you.
Yeah, nice to see you. Thank you very much for inviting me. Bye, Ashraf. Bye-bye. Bye.